Thank you, everyone, and welcome. Good afternoon or good morning, depending where you are in the country. I'm Jen Mills. I have the pleasure of leading our medical affairs team here at Foundation Medicine, and I'm super excited to be here today to highlight a spotlight celebrating Hispanic Heritage Month in cancer care, which is a joint collaboration between our Med Affairs team as well as one of our oldest and strongest employee resource networks here at Foundation Medicine, which is BAHA, our Black, African, and Hispanic Alliance. Before I jump into our introductions, I want to just give a huge shout out to Jen Eubanks, Cindy, and others that are part of the leadership team for conceptualizing this program and connecting with Dr. Mesa to bring this great discussion to all of us. So in the spirit of full disclosure and transparency, our respective disclosures here, as well as our financial and employment disclosures on the next slide. And with that, I will not waste any more time before introducing our incredible featured speaker today, Dr. Ruben Mesa, as well as Jen Eubanks, who is our oncology nurse strategic account manager and one of the co-leaders of BAHA here at Foundation Medicine. So if you remember nothing else, one of the most critical components of Dr. Mesa's most stellar experience across the cancer ecosystem is that he is the first Latino leader of any NCI designated cancer center. This is a huge honor and a huge inflection point for the NCI designated cancer center program. I looked back and there are over 70 NCI designated cancer centers. So the fact that that program has been in existence since the 70s and Dr. Mesa is the first to represent the Hispanic and Latino community in this really prestigious role is really incredible. So among this accolade, he has many other significant contributions across the cancer community. He is currently serving as the president and executive director of Atrium Health, Levine Cancer, and Atrium Health Wake Forest Baptist Comprehensive Cancer Center. That's a mouthful. He also serves as the vice dean of the cancer programs and has a really impactful role across this ecosystem. In addition to his current role, Dr. Mesa's history extends well before his transition to this role. He's a world-renowned and international expert in heme malignancies and has also been a really star luminary in the field of health disparities. You see here he's got over 8-time lifetime medical publications, which is a huge number even among his peer group. And we're really thrilled to be able to have him here. I'm going to, before I turn it over, I'm going to also introduce you to today's moderator, Jen Eubanks, who is an oncology nurse that we are so thrilled to have here as part of our team at Foundation Medicine. She has over 20 years of seeing patients in direct care and continues to serve as a nurse supporter in an underserved community health center in the Chicago area. So Jen, thank you. I'll turn it over to you to continue the discussion.
Thank you so much, Jen. And again, thank you, Dr. Mesa, for being with us today. And I'd love to start with just your background. Like, I know that you're a world-renowned hematology expert and sincerely a trailblazer in this space. Can you share a little bit more about your Hispanic background and what these achievements mean to you and your family? And I'd love to talk a little bit more about the beautiful picture here as well.
So let's start with my lovely family. So my wife, Chris, my son, Ruben, my daughter, Katie. This is over the holidays up in northern Wisconsin, where we enjoy a cabin and enjoy spending some time together over the holidays. I myself, as you mentioned, am Cuban. My parents were both from Havana and left Cuba, escaping the Castro regime in their teens. Married, and then I was raised in Chicago. Did my medical training at Mayo Clinic in Minnesota. Was there on the staff, and then moved to Mayo, Arizona, where I led the cancer service line, chaired HEMONC, was the deputy director for the Mayo Cancer Center. And then in 2017, moved to San Antonio to become the NCI Cancer Center director for the Mays Cancer Center in San Antonio. And at least I have been told that I'm the first Latino Cancer Center director. I can't validate that 100%, but I've heard that from multiple individuals. The good news is that the Cancer Center directorships are becoming much more diverse. So now we have Dr. Yolanda Sanchez, the first Latina Cancer Center director at University of New Mexico, Dr. Carlos Arteaga at UT Southwestern. And overall, there are more underrepresented minorities as directors. My good friend Rob Wynn, Kunle Odensi, and many other, Selwyn Vickers, on and on. So we have a much more diverse crew. I think it's really been both an honor to kind of be one of the first in these sort of roles, as well as I think very helpful, both in terms of junior faculty, people earlier in their career, later in their career, really seeing, individuals with similar backgrounds to themselves, having these opportunities to be able to lead important programs, and have significant impact. Two, I think it's very helpful in terms of perspective. I think having a diverse group of leaders brings different perspectives, different backgrounds, different cultures to these roles. When I led the Cancer Center for South Texas, which is a Latino majority population, being able to hear from the Spanish-speaking population about the cancer needs from them in their language, being able to address those, working on advancing the science of cancer in Latinos. We realize that the Hispanic community is a very diverse community in and of itself, with many different experiences, influences, genetic influences, and others. And again, that makes it a rich community in terms of experiences. There are also very different origins of health disparities that can arise. And again, having that perspective to really bring these different backgrounds, to that shared fight.
Yes, and thank you so much for that. And that's a great transition to my next question. You published over 800 times. We saw, and a lot of your work is in addressing health disparities. And can you share with this group today some of the talking points that you often educate on, regarding this and regarding reaching patients in these rural minority populations and addressing these inclusive trials and creating the multidisciplinary teams that you're doing at Atrium to kind of reach these most vulnerable patients?
Well, I fortunately have had the opportunity to try to contribute to a really important area, which is cancer health equity. And now I'm one of the cancer equity leaders helping advise the NCI Center for Cancer Health Equity. And it's really multifactorial. One, we clearly have learned that challenges with social determinants of health is one central piece. Issues with access, and other barriers, whether they be transportation, support, and other things are barriers, but there are many. I frequently had the conversation with our Associate Director of Community Outreach and Engagement, Dr. Emily Ramirez, that, in South Texas, if, in one hand, we had the cure for cancer, but it only could be administered with the limitations we have today in terms of insurance, access, early diagnosis. Or on the other hand, everyone in South Texas would get healthcare according to current guidelines, including prevention, screening, good nutrition, lack of food deserts, early cancer screening and therapy, which would have the bigger impact on mortality and cancer. And we were both strongly in agreement. It really was the latter, that, again, we can have some really fancy cure, but only if 30% of the people can obtain it, then it's not going to, really have the same impact that it would otherwise.
Absolutely. And you've mentioned before in some of your discussions, even criteria, inclusion criteria with this population, and getting them enrolled in clinical trials versus excluding them. Have you seen any pathways or any changes in that regard?
True. So with clinical trials, I had the honor of testifying before Congress on legislation that became law regarding having clinical trials be more reflective of, our general population. And I think that's incredibly important with barriers, whether someone is rural, whether someone has issues with social determinants of health, or language, or culture, or health literacy, all can be barriers. And with that, there is now with the passing of that legislation that drug trials seeking FDA approval really need to have a plan to address so that accrual really more matches the community. The benefit of this, I think, is really twofold. First, it's more just. Cancer clinical trials are a key way that we treat cancer, and lack of access to cancer clinical trials, direct or indirect, limits the options a patient has. And second, it's good science. If we're not testing the drugs in the people who are actually going to be receiving them, then we really are flying blind in terms of knowing whether these therapies are going to be safe or whether they're going to be effective. Now, as I've sat on efforts with organizations that have looked to try to increase diversity on clinical trials, there's multiple angles that are taken. One, training the next generation of investigators to be more diverse or more sensitive to these issues. The WIN Scholar program that's been supported by the AACR, the VCU Massey Cancer Center, and BMS. Or issues such as how the trial is structured, remote visits, how burdensome is it for the patient to participate in the study, as well as eligibility criteria. Many clinical trials have incredibly conservative boilerplate eligibility criteria, but some of which really introduce intrinsic bias. In South Texas, many individuals have some mild degree of elevation in their liver function test due to fatty liver disease and others. And there's many contributors, including diet and other pieces that contribute to that. I found as I moved from Arizona to Texas that the number of patients who became ineligible due to really strict criteria for liver function, renal function, even when not scientifically justified, were very limiting, and then limited access to those clinical trials. So clinical trials are really a distillation. If we're really going to have an open and just process for testing therapies, it needs to be inclusive. And that includes everything from the consenting process, how we educate patients, how we create trust in communities so that individuals feel that they can participate in trials safely, as well as that they truly understand their participation. When we were doing translations in South Texas, we had learned that if you're using straight translation, even the word clinical trial, amongst the Mexican American community, using translations of the word study were much more better received. A translation of clinical trial implied a legal process that both was very disconcerting for individuals and clearly not representative of what was intended.
Yeah, that's a great point. Just having the correct translation, of what makes sense to the participant. And I'd love to kind of piggyback off of that on your clinical insights and the role of genomic testing. How and kind of how that fits in with this health ecosystem, and how really the role genomic testing plays with the ecosystem, and how we can help address health disparities in the regard when it comes to genomic testing.
Well, this is an incredibly important piece. As I talk with our trainees and fellows, cancer clinical trials have strongly evolved, as have our therapies. When I was a fellow, there was a frontline breast trial, a frontline lung cancer trial, frontline leukemia trial. And if you had, breast cancer, you were eligible for the study. We now, fortunately, have much more targeted therapies that typically have, one or multiple aspects that narrow the focus of a trial based on genetic markers, likelihood of response, prognostic features, and others. And this has led to, more efficacious therapies. We clearly have therapies that are much more impactful for solid tumors now and liquid tumors than we have in the past. And the advent of genomic medicine has been central to that precision oncology piece. And there's relevance both on the safety and efficacy side. Even aspects of pharmacogenomics in terms of metabolism of therapies can be very relevant that impact dose and others. If an individual does not have access to that sort of testing, it is incredibly limiting because you don't know whether you're eligible for these therapies to begin with. If that isn't known, all of those options really become invisible to you. They cannot occur. They are central to being able to really utilize therapies and test them appropriately. I'll use an example. One of the early ones in the era of precision medicine, the therapy imatinib is incredibly impactful for chronic myeloid leukemia. But one needs to have the BCR-ABL mutation to really, be responsive to that therapy. When that therapy was approved, it was offered to the people in underdeveloped countries, but only if they could prove that they had the molecular mutation. And then it was really the barrier to having molecular testing that was really the barrier, because if you couldn't prove it, you couldn't get the drug. And the drug was incredibly impactful. So I think it's incredibly important, and genomic testing has really evolved from being a luxury to being essential. And I think that is really the fundamental piece. When I was in San Antonio, there was an incredibly generous county-based program that would cover the care for individuals if they resided in Bexar County. So that was very generous. But we had to really work with the leadership of that team to evolve to cover genomic testing, because we had to make the case, and the case was made successfully over time, that genomic testing was not about pure research. It was not about, interesting abstracts or papers being presented at national meetings or high impact journals. It was really essential for being able to provide care, whether that's in lung cancer or, cancer of unknown primary, or on and on. So it really is an essential piece. And I think that real movement that, in the underserved or individuals with, challenges in terms of social determinants of health, genomic testing is not a luxury. It is essential for treatment planning and for the proper identification of eligible clinical trials.
Absolutely. Yes, thank you. Thank you for sharing that. I know I'd like to make sure we have enough time for the group to ask questions. And before I do that, I just want to sincerely thank you on behalf of the Black, African, and Hispanic Alliance for really your dedication to patients and being a role model and trailblazer in this space. I have one last question before I open it up to the rest of the group. The BAHA Alliance has been sharing some fun songs on Spotify. So if there's a song that you'd like to add to that list, one of your favorites, some canciones buenas, can you share with us what?
Well, for me, almost anything from Celia Cruz, so some good salsa, always is a welcome tune.
All right, Cindy, we got to add that to our playlist. So I'd love to open it up to the group. So we have a wide variety of people here at Foundation Medicine that support our mission. So please feel free to either put in the chat. It looks like Cindy, go ahead, you can unmute.
My first question is, what is your favorite Cuban dish?
Oh my, well, of course, it's hard to beat a great Cuban sandwich, but particularly in Miami, you get that Cuban bread. You get that scrunched down real nice with some croquetas, some aterba. Hard to beat, particularly if you go to Versailles, the classic Cuban restaurant there in Miami. Get a little cafecito and a pastelito on the way. Fantastic.
Sounds delicious.
Absolutely. Anyone else from my colleagues that has any questions for Dr. Mesa before we end this afternoon? You can put it in the chat or unmute. Go ahead, Randy.
Hey, Dr. Mesa, good afternoon. Thank you for spending some time with us today. We really appreciate you. I'm curious if you could share with us as to how you educate your docs on the importance of genomic testing. As you know, 30% of physicians, oncologists are still not ordering the testing in the community setting. I'm curious if you could share with us how we can better educate the docs and compel them to start looking at this testing as its standard of care.
Sure. So, and most certainly it has become standard of care. And certainly, very grateful of the efforts of Foundation and all the efforts that you guys are doing. I think part of it is being done, but it's evolving in terms of, how the genomic information is being integrated into the electronic medical record to really help facilitate that decision making at the point of care. That's a really important piece. There's both information, but then kind of how you leverage that information. In our large comprehensive cancer program, we of course have our molecular tumor boards, as well as try to incorporate this information in each of the disease-specific tumor boards. So I do think part of it sometimes in groups where individuals are in smaller groups, or the limitation is really that infrastructure of how do we leverage that key information in terms of decision making. That really ends up becoming kind of the key piece. For the busy oncologist, not only what is it there, but what are really the implications, both in terms of things that are expected, as well as I think increasingly having germline information to be able to separate out what are tumor specific information that is relevant versus being able to sort out things that are germline and unrelated or have different implications. For example, I care for patients with heme malignancies, but some of them will end up having, CHEK2 mutations that maybe have implications in terms of risk of breast cancer. That again is totally far afield from the reason that I ordered the testing, but is relevant and something for us to sort out.
That's a great segue to one of the questions in the chat, Dr. Mesa, that Kai was asking if you've noticed any specific driver mutations in the Hispanic community or specific tumors that are more prominent.
Certainly we see that not necessarily explained on a genetic mix. And again, Latinos, as it relates to genetics, is very rich. There are many different aspects that are in there from Africa, from North Africa, from the Iberian Peninsula, from many indigenous cultures in Central and South America. So it's a very rich and diverse genetic pool. But there are important observations that have been made. So, for example, investigators at UC Davis, did work comparing Latina women who were of either European extraction or indigenous extraction, and actually found that there were some mutations that were protective against breast cancer in women who were of indigenous Latina origin that were different than women who were of European Latino origin. And I think some of the richness of this genomic information combined with really ethnicity and really kind of regional genetics are really quite interesting, and will give us, I think, further clues, into cancer. You've noticed I've not used the word race, in part as we've learned, that's such a social construct that it really isn't super representative of really what we're trying to discuss. We know well individuals that have been labeled as Black clearly are incredibly heterogeneous. And the genomics from, East Africa versus South Africa versus Central Africa versus West Africa versus Afro-Caribbean or Afro-Brazilian are all going to be different, and we need to start thinking more and more in those directions, as opposed to thinking these kind of monolithic groups that really are much more diverse than they seem.
Yes, thank you. Do we have time for one more question? How are you doing with time? I know you have a hard stop.
Just one more, because I have to hop on something else, but it's really been a great honor to have this invitation.
Well, it looks like Ashley was curious, the 30-second overview of what your cancer center specifically is doing in regards with improving diversity with the enrollment process that we kind of touched on with the clinical trial enrollment process.
Well, wonderful. So many different parts. We have a minority accrual plan for each trial. We have population health navigators that are specific to populations with expertise around language or culture or community connections. And then our community outreach and engagement program is led by Dr. Nadine Barrett, who's the current president of ACCC. And she started an initiative called Just Ask, which is really central to what we do, that again really begins with the assumption that people want to participate in clinical trials. How do we facilitate that? Just ask. is that her work had helped to demonstrate that, one of the barriers is the incorrect assumption that people don't want to participate in clinical trials, where in fact, properly described and otherwise, they likely will.
Great. Well, that's a great way to end. I know we're right at the half hour, so sincerely thank you so much, Jen. I don't know if you wanted to say any closing remarks for the group, but this has been a real honor and privilege to have you join Dr. Mesa. Thank you so much.
Yes, I'll just add my thanks as well. And thank you to everyone for joining. We look forward to seeing you in the next program.